Welcome to the November 5th Addiction Toxicology Case Conference. This is brought to you from the American College of Medical Toxicology and the American Society of Addiction Medicine as webinar partners. Please visit the FAQ page from prior Addiction Toxicology Case Conference webinar series FAQs. These are put together through a grant from the Opioid Response Network and include some excellent information. I'm Dr. Tim Wiegand, the Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester and Professor of Clinical Psychiatry in the Department of Psychiatry, also at the University of Rochester in Rochester, New York. And we have joining us today Dr. Ross Sullivan, who's the Director of Medical Toxicology at the Upstate University Hospital and Director of Emergency Medicine Opioid Bridge Clinic and the Medical Director of Helio Health, Syracuse, New York. And two expert panelists, Catherine Chineo Komatsu, licensed counselor and social worker, guest expert at the Mount Sinai Hospital, adjunct lecturer, Columbia School of Social Work, New York, New York, and Dr. Linda Wang, assistant professor, general internal medicine, Department of Medicine at the ICANN School of Medicine at Mount Sinai, New York, New York. And just before presenting, I want to announce the call for abstract submissions is still open, but the deadline is closing soon. November 15th for the March 11th through 13th meeting for ACMT in San Antonio, Texas. This will be a hybrid conference. None of our speakers have any conflicts of interest to disclose, and we'll jump right in. It's a complex case that's, if you don't take that out of my chart, I'll sue. So I want to encourage everyone else to, in the audience, to please use the Q&A for questions and comments. We will incorporate some interactive discussion, and they're looking for audience comments. This case is a case-based discussion for a hospitalized patient with chronic pain and addiction who has concerns about the electronic health record documentation, the stigma in her diagnosis, and provide some context for discussion of some ethical issues in the treatment of substance use disorders and addiction. And I'm going to go through the case. I don't want to get bogged down in the details of management in the hospital, but this sets really the context for questions and discussion. We have a 37-year-old female presents to the ED. She's hospitalized for pain in her left hip. It's been increasing over the past week, and there's concern she has osteomyelitis and/or septic arthritis. She has a very complex medical history, including suffering multiple fractures from a car crash. She's a passenger. This is about 5 or 6 years prior. She had long bone fractures in her left leg, tibial plateau fractures that didn't heal well, were complicated by infection, and she has fractures of her left foot and ankle and required not only reconstructive surgery, but numerous orthopedic procedures and several courses of prolonged antibiotics and some hardware removal. So this is a very involved injury and multiple surgeries. She's been left with disability and limited gait and movement due to her injuries. In addition to the trauma and pain, she has fibromyalgia, hypertension, has been diagnosed with anxiety, depression, and ADHD. The patient has chronic pain from her orthopedic injuries, neuropathy, fibromyalgia, and she has deconditioning complicating all of this. And for years, she has had extensive pain management with various high-dose opioid regimens from several different area pain clinics and primary care providers. Currently, her pain is managed by a new primary care provider that's prescribing buprenorphine mono product, 8 milligrams sublingual TID, pregabalin, 200 milligrams 3 times a day, duloxetine, 60 milligrams once a day, naproxen, twice a day, acetaminophen, 1 gram 3 times a day. As she's being evaluated and treated for infection, her blood cultures return positive for gram-positive cocci, and imaging is being ordered and then obtained, CT and then MRI. She's upset about her pain management and treatment. She's been refusing the buprenorphine doses, was given an initial dose of hydromorphone 2 milligrams IV in the emergency department shortly after arrival. And orthopedic surgery had ordered oxycodone 10 to 15 milligrams every 4 hours as needed for moderate to severe pain. But she's insisting on higher doses of oxycodone and that parenteral hydromorphone be added in. The patient had been transitioned to buprenorphine about 4 weeks prior to this hospitalization after her pain medicine provider stopped prescribing other medications, the other opioids, after an overdose, which she disputed. That episode, she had been found by her mother, who frequently visited her, on the floor of her apartment, unresponsive, and she was having twitching. The mother called EMS, and medics noted bradypnea, the meiosis, and tremors and twitching, and they administered 4 milligrams of intranasal naloxone, which caused her to wake up and abruptly have significant withdrawal symptoms. As she was brought to the emergency department, her mother and medics gathered her medications and some of her medication counts were dramatically off. She was 1 week into her prescriptions, and she had most of the oxycodone, 30 milligrams, missing. The sustained release oxycodone, 60 milligrams twice a day, there were only a few tabs left, and an amphetamine bottle, 20 milligrams, sustained release once a day, was empty, and this is 1 week into the 30-tab prescription. The pregabalin had about half of the bottle left in some different capsules that were later identified as gabapentin mixed in. At that visit, her urine drug screen in the emergency department was negative for opiates. Of note, oxycodone was not tested for, it's a different assay, but it was negative for amphetamines and positive for cocaine. And this was not a broad screen that included fentanyl. The patient adamantly denied using other opioids, admits that she may have taken an extra Lyrica, denied use of cocaine, and told the ED admitting team that she must have been robbed and drugged. And her mother disputed that, and so that was not pursued other than the initial discussion and examination. A tox screen done in the emergency department. Prior, we have some results here that after the OD and is available for the, and shows a positive cocaine, negative opiates again, oxycodone wasn't tested for, negative for amphetamine. And in this ED visit, now when she's coming in with concern for osteomyelitis and septic arthritis, she has fentanyl come up on positive, on expanded results. She was not given fentanyl, and she is negative for amphetamine, and she does not have any buprenorphine in her system. The less than 25, less than 2, less than 5, those are buprenorphine metabolite levels that are negative. And she also has cocaine. She says that she might have missed a day or two of the buprenorphine because the pain was too bad. I couldn't get out of bed to get it. After the overdose, the patient was admitted due to the pain in her leg because she had mild rhabdomyolysis and leukocytosis. And her pain providers advised a chemical dependency consultation, which she refused, although she did agree to try buprenorphine in the context of her pain providers being contacted and not prescribing any further full agonists. She was transitioned onto initially dual formulation buprenorphine, but reported headaches, so she switched to the buprenorphine mono product at 8 milligrams 3 times a day over a 3 to 4 day period, and ultimately linked to a primary care provider that prescribed buprenorphine for opioid use disorder as well as pain. And the patient is adamant she wasn't overtaking her meds, very upset about the medication changes, but agrees to follow up with the primary care provider. The pregabalin was continued. Said the only thing that works for my fibromyalgia and is even touching the pain in my leg. And again, the adjunct of acetaminophen and non-steroidals are added at the end of the hospital stay. And in that visit, the 4 weeks before after the overdose, is a concerning note in the chart from a nurse documenting finding a half a tab of buprenorphine in the bed and a partially disconnected IV tubing with an empty saline flush while the patient was sleeping. This is just during routine medical cares. The patient reported the flush had been left by prior nurses and she must have fallen asleep, taking the buprenorphine and part fell out of my mouth, she says. And nursing observed each dose after this, and the patient was discharged with a 1 week prescription and follow-up. Misses the follow-up, Medicab didn't show. She asked for another prescription and another appointment is made. She misses that appointment too due to the pain in her leg. And she does go to an urgent care for pain, had been given 10 milligrams of oxycodone there, and it had an x-ray, which didn't demonstrate any changes from prior films. She was afebrile, but had a really slight leukocytosis. This is about a week before coming into the emergency department, where now we have concern for osteo. The pregabalin and buprenorphine and other medications were filled with an appointment scheduled for the PCP, but she's hospitalized with the current admission with worsening hip pain, fever, white counts, and elevated SED rate and CRP. And orthopedic surgery is consulting addiction medicine for an evaluation and assistance with medications and pain control. So my questions for the panelists, I know that's a lot to go into, to comment on how would you approach this patient with the information from the recent hospitalization and screens available, some other notes from the pain clinic. There were also some other urine screens with inconsistent results. And then what are some common areas of missed opportunity, bias, and stigma for patients with substance use disorders and addiction that occur in the emergency department in the hospital setting? Catherine, I'll start with you. What comments or thoughts do you have for this?
Yeah, I mean, for me as in my role as a clinical social worker, I would be curious to understand the patient's relationship and history and experience with the different medications, with their experience in the hospital setting, like what brought them into the ED. Like I would want to kind of have a clear understanding of that, because also there's like this main it sounds like a question from the medical providers or the hospital setting, is this person misusing the medications? How come? And also seeing other substances in the urine toxicology. So from my lens, it would be like, what is the relationship to all of these different substances or medications? I would want to understand why the changes in meds from the client's or patient's perspective are not favorable. Like, what is the best case scenario from this person's lens? I would want to know as well. And I think from the lens of like, what are some missed opportunities or bias or stigma that can come up? From my lens and experience, it's people that we work with not wanting to be seen as addicts or as substance users, because it does bring in the provider or like the person that's treating them, their bias, the moment that this kind of label is provided or given. And I have seen it, right? I have seen it from direct experience that people get denied services and cannot access care if they are seen as actively using. So I think the patient's kind of relationship of not wanting to be seen as such in particular is expected. And I would find it to be reasonable, right? So I am normalizing that experience because it's a real lived experience in medical settings where people get labeled and therefore treated differently. Drug seeking, instead of like, I actually have a sensation, a feeling in my body that I want to address with your help and support. So those are some of my thoughts. Thank you.
Those are great. Yeah, thank you. We had a recent case in which, and this happens all the time, back pain was, mislabeled as drug seeking and was epidural abscess. And, and I've unfortunately seen that occur numerous times. Dr. Wong, do you have any comments on how would you approach this patient? Established rapport. She's got a lot of comorbidities and a lot going on.
Yeah, I mean, it's clear that she has a significant pain history with prior surgeries and also an acute reason to have severe pain in the immediate setting. She obviously has a baseline chronic opioid tolerance, right? And so, that's important to keep in mind. And I actually think it's a positive thing that someone had started her on buprenorphine prior to this hospitalization. She had taken it before, and so. Obviously, clinically, I would continue the buprenorphine while she's in the hospital. She's already taking it split dose. And I think it sounds like she was at 24 milligrams already. And I would add on other full agonist opioids to treat her pain. And I think we know that patients with baseline opioid tolerance and who may also have opioid use disorder, you really have to be giving them opioids that are sometimes 3 times higher than the usual patient. And so, I think back to this patient's comment about wanting IV hydromorphone and wanting her pain to be treated. I think that's a red flag for me that this patient is really worried about having her pain undertreated in the hospital and not being taken seriously, even though she has significant reasons to be in acute pain. So I would, I recognize that. And I think as providers, we need to be conscientious. Sometimes that's seen as in the hospital as a behavioral problem or they're drug seeking. But in fact, it's because the patient has uncontrolled pain. And I think to Catherine's point, like, what can I do for you today? How can I help you the most? Like, what is your priority? Like asking those questions. And I'm sure for this patient, her priority is to have her pain treated, right? And so if we don't acknowledge that and listen to that and try at least as much as possible to treat the patient's pain first, they may not stay in the hospital to get the rest of their medical treatment. So that's important to me. And to add on to sort of this, the second piece for Catherine that Catherine started talking about in terms of bias and stigma, I do think that there's a often missed opportunity to really talk to patients about their relationship to what they're using and their relationship to their pain. And I think it's really important to communicate openly with patients, right? So that when they do read their chart notes later on, they're not surprised by some of the language that we might be using. Patients may not understand that opioid use disorder is a clinical diagnosis and that it actually is something that we in the hospital use to communicate between providers to ensure that patients are receiving the best treatment and the most appropriate treatment possible. So I think open communication is important. I think saying things like, I can see and recognize that you're in a lot of pain, and it's my goal to try to address those issues for you. And what are some of the other things that you need help with today? Or even acknowledging and normalizing that sometimes patients like her don't necessarily always get the best treatment in the hospital, right? I think that is an ingrained fear for a lot of people when they come into their hospital. Their defenses are up, especially people who use drugs and people with substance use disorders. Their defenses are up, they're in survival mode. So some of the things that they say or do may be misconstrued as being problematic or drug seeking, but in fact, it's a way for them to survive and try to at least get what they think that they need. And so as providers, I think we need to be open to that and to be more conscientious.
Yeah, those are really good comments. I often will start, I'm here to help. I have no interest in having you suffer, and I want to make things better, but let me hear your story. And also then I'm reminding the patient that I have reviewed the chart, and so I do know what's going on. So it's not like, haven't you looked at any of my history, but doing a lot of listening. Dr. Bishevitz, do you have any comments, or are there any? Is there anything in the Q&A or chat from the attendees?
Well, I think that we've covered it. There is a new thing in the chat saying that I hope we discuss viewing chronic pain as a combination of pain and surrounded by suffering, the model that Dr. Mel Pohl from Las Vegas Pain Center uses. So pain and suffering. If we can decrease the suffering, then the patient can tolerate the pain. So I wonder if there'd be any discussion of that.
That
Yeah,
makes
that's
sense.
a really good.
Yeah.
Go ahead.
I was just gonna say that it makes total sense, right? Like I'm a yoga teacher as well, and I do offer a wellness group in the setting I'm in because and even talking about harm reduction, we've read a couple of articles that have added, right, like a view of harm reduction and health and happiness, right? Like including that as well, because that also is part of the work, right? Harm reduction sometimes is focusing on like reduction of harms, but this other kind of perspective of health and happiness is also bringing in the joys that we experience through, our dynamics and relationships and connections to things. But pain in particular, right? Like that is such a subjective experience that really has to do with the person's lived experience. And sometimes pain, physical pain, right, manifests because you're having mental health pain or because you're having emotional pain, because like I feel like there are connections with our mind, bodies, the experiences we've had in our lives and how we carry those things that we don't often talk about, So I'm gonna look into this center because I had never heard of it, but yes, decreasing suffering and addressing more than just the physical or physicality of these pains, but also what are kind of like the roots or etiology. I always think of like, what are the roots of this pain? Where did this originate? Because sometimes it is through an accident or something like that did occur, or other times some form of kind of disruption in the person's life.
Mm-hmm.
Yeah. So comments. This patient has a lot going on, and she had a lot taken away from her in terms of her life with the trauma, the disability. She is using high doses of opiates as hyperalgesia. We don't know a lot about her relationships and social setting. She has a mother, but does she have other supports? What are her friends? Dr. Ed Selsitz has an outstanding lecture on pain and really talks about the various factors that will impact an individual's perception of pain, and how suffering is very different from pain, and we can talk about that. I do want to comment on the Dr. Wong had mentioned getting buprenorphine back in place and using full agonists on top. I think that's a really excellent technique. And this patient had stopped taking the buprenorphine for we're not clear how long, but had not been taken in, so we'd have to do something like a microinduction. But there's some other factors in this case I want to talk about, not just simply focus on pain. Dr. Sullivan, did you have any other closing comments before we move along?
I think everyone really nailed it. To just, remember that people who have substance use disorders to opioids and other things can have real pain. And, in the emergency department, you see it all the time. And, sometimes they're still called seekers and things like this. And, this is a patient that with, a real life painful driver amongst all the complex other issues everyone already brought up. So real life pain does exist in all people, including this population as well.
Yes, and she certainly has good reason to have that. So after establishing rapport, primarily listening to her story and background, in particular related to the motor vehicle crash, patient tells the provider, they keep trying to have someone from chemical dependency see me, or they send me to treatment, but I need pain control. And she has not gone to treatment, but meaning they want to send her to treatment. And then the provider tells the patient that, well, right now we want to get the medication regimen set up so pain control is appropriate, infection stabilized, and some tests completed, and really sets a basis for trying to have ongoing rapport, which includes restarting the buprenorphine, the microinduction, and some other techniques. During the discussion, the patient denied IV drug use and denied overtaking her opioids in the past, except for certain reasons. She said, if I fall, there's been some procedures, some pain exacerbations, and then to help me sleep sometimes. So when let talk, she goes on about context and where she would take some and run out. She has tobacco use, denies alcohol, occasional cannabis, but not in the last few months, denies the cocaine, although the 2 recent ED visits with cocaine positive. And she talks a little bit about past urine screens and prior ones being out of context and having some false positives, or they don't test for oxycodone, which is very true in terms of some of the tests. And she has a lot of knowledge of urine drug testing as well. She has some signs of an exam of, which a lot of signs of the obvious trauma, and she has some signs of injection stigmata, but this is hard to differentiate really. I mean, she's had many IV attempts over the years and recently in trauma and injury, so the signs are not that dramatic. So it's not really clear that she's clearly injecting any drugs. After a long initial interview and chart review, the provider documents the history and assessment, including concern for opiate and other substance use disorder, and brief mention of the past hospitalization with nursing note related to possible IV tampering and finding the half tab are referenced in the overdose and the overdose naloxone administered as part of the background and history included in the initial note. And the provider makes recommendations on restarting buprenorphine microinduction with higher dose full agonist concomitantly 2 to 3 times standard doses, along with this multimodal regimen with acetaminophen, nonsteroidal, and duloxetine, and then comment about pregabalin and potentially tapering that down, reassessing effectiveness of that. The patient is able to read the provider's note via patient access portal, along with other notes, test results, data labs, and communication to and from providers. And she's livid about the diagnosis and demands to see the addiction provider. She wants any reference to substance use disorder addiction removed, and a few other things related to this overdose, which she disputes. She doesn't deny naloxone was given, but that she had been taking pregabalin for pain and comments that an assault and robbery hadn't been pursued, and she's upset about that. She's an attorney, she mentioned, one that helped with the crash and some medical issues after. She implies lawsuits related to infection, and she says she's going to contact this attorney if the chart is not fixed. So my questions to the panelists and the audience: have you ever been asked to remove something from a patient's chart or alter wording? And if so, what was the context and how did you proceed? And then how do you respond to this patient specifically? And then third, some electronic health records have options to no-show notes from patients. And what context might this be considered? So Dr. Sullivan, we'll start with you. Have you ever been asked to remove something, and the comment on the other questions?
Yeah, I have been asked to remove some things, and sometimes it's been in this context. Sometimes people will say things about their insurance companies or their doctors knowing things, or just that it's not correct. And unfortunately, how do you proceed? It's sometimes these patients don't understand. These are not only medical records, but they're also records of legal medical safety net, as well as historical documentation what happened to the patient. So, I really try to explain to the patients that, these notes are kind of like a medical legally almost like binding thing. We can't really change them. Sometimes it will say, well, how can you alter your wording? And I think it's important to, when you talk to the patient, the words you use with them will probably be words that you might use in your note. So, I try to not use the words like addict or, even addiction in all these things. So I think, ensuring to the patient that when you, write your note that, you're going to, talk about the truth of whether that you're going to use non-stigmatizing, non-judgmental words. That normally works, unless somebody flat out is asking you to, tell a non-truth or a lie. So, that's where I try to work it. This patient's a little bit different because, she's has a clear pattern of probably a substance use history, and whether she knows it or not it's a different question. But I think that you just assure her that you're going to use non-judgmental, stigmatizing language in all your notes, and hopefully that will make the situation a little less tense.
Yeah, that's good. Thank you. Dr. Bashevitz, do you have you been asked to do them? What do you do?
So actually, I have not been asked this specific question, probably because I work fully in a chemical dependency program. So everyone has these diagnoses. But the question of where you might go from here and how would you proceed with the patient, I would just talk with the patient and, maybe go over other aspects of the chart and that kind of thing. I think that can help.
And Dr. Wong, do you have any comments? Have you been asked to alter a chart?
I have not been asked by a patient specifically to alter a chart, although I have asked other providers in my institution to change the phrasing and the wording, because it's very common for me to see trainees and other faculty document things like addict or polysubstance abuse in the chart, and it drives me insane because they're not appropriate, accurate clinical diagnoses and can persistently stigmatize a patient every time they show up to the hospital. Because as we all know, in the era of electronic charting, everybody copies forward a chart note. And so once that word is in someone's chart, it lives with them forever. And so what I end up doing is hounding people to change specific words and phrasing, because not only is it stigmatizing for the patient, but we know from studies that actually language really matters and can prevent people from receiving adequate evidence-based treatment for a substance use disorder, and can result in that patient receiving subpar care and maybe even experiencing punitive actions as a result of that language. And so that's really problematic to me. And so that's something I'm very attuned to. But sometimes I do wonder, when I write opioid use disorder in my patient's chart, which is their DSM-5 diagnosis, how are they going to take it? I think not all of our patients agree with the use of the word disorder, right? To them, that may be something that they are concerned about. But unfortunately, it is the language that we use clinically to communicate with each other and to be able to prescribe certain medications that are approved for the treatment of that diagnosis. So I do try to explain to patients that this does not define you. This is a clinical diagnosis we use to be able to provide XYZ treatment. But I am conscientious about that, because I also know that for some of our patients who are discharged from the hospital, and I think Catherine can speak to this more eloquently, having a diagnosis of opioid use disorder can prevent them from getting wound care after they leave the hospital and from getting skilled nursing needs. And that's just crazy, but that's the world that we live in, because we still continue to stigmatize against people with substance use disorder. So I'd love to hear from the audience if they figured out a way to finesse that or negotiate around that, because I think we're still working through that process. And with respect to the no-show notes, I think that what's recommended is, if you feel like your note is going to cause significant emotional or personal harm to the patient, I think, select it. But I think there's also been some emerging evidence that having open notes can be helpful for patients to really be able to share an understanding of what's going on and also provide feedback. And I have heard increasingly that some providers actually, mostly in the harm reduction world, will co-write their notes with other people, with the patients, So they'll like turn the computer around and show the patients what they're writing and write it together, which I think is actually a really interesting and great model to really provide patient-centered care.
Yeah, that's a great comment. I think you had several excellent comments. First of all, editing notes can be very appropriate as medical professionals, trainees. We may have inappropriate language. Also, the context of the notes may be misinterpreted. If I have a patient that's really doing well in the outpatient setting, but CPS is involved, and they may have had one screen positive or something. So documenting really the tone of they're doing well, working hard. Here's where their things are positive, and context of having a positive screen but being compliant with medications needs to come through so that it's not interpreted as, this is still a struggling individual and out of context. I've had a patient I'm working with who has anoxic injury from an arrhythmia for methadone a while back, and she's not able to get wound care, visiting nurses, and because of the substance use disorder, and wasn't able to be placed in a skilled nursing facility after due to being on a medication for opioid use disorder. So they're very real examples of, even when appropriate medical terminology is used in a non-stigmatizing way, there are barriers to healthcare. I think Dr. Sullivan, we were talking last week about a specific example that you had. There's some unexpected ramifications from an individual, I think either legally or citizenship or something that came up when there was a diagnosis. Do you want to comment on that?
Sure. We had a case at our community behavioral health, Helio Health here, and it was a gentleman of I believe of a Latino origin, and he was applying for citizenship, but there's a form you can fill out that basically says that if you have like a psychiatric or something or IQ limitation, you don't necessarily have to go through the normal process to acquire citizenship. And in the assessment by one of the psychiatrists we work with, it was deemed that the patient did have an alcohol use disorder based on just interview and history of the patient. And when the patient brought this back to the patient advocate for citizenship, that person and the patient both called back and asked the psychiatrist, myself, and everybody to please remove that from the form, because it wasn't necessarily what the form was asking for. It was just asking for other diagnoses, and that he will not be able to get citizenship with that on the form. So they basically told us / asked us to remove it. So that was something that I've never encountered before. So we felt strongly that we could not remove it because it did say, were there any types of other disorders or use history. I think we tried to maybe use as non-stigmatizing language as possible. And I think that maybe we offered to rewrite maybe how it was written, but we did not remove the diagnosis from the form. So in the end, you still have an ethical obligation though to, in our standpoint to, answer questions, the way you still have to. But what was interesting is that the patient also had a cultural, I guess, what would I say, a thought and idea that perhaps, he wasn't an alcoholic, or the alcoholism was also very negatively viewed in their culture. So it was a very multi-compartmental problem, almost one that I wish we had an ethics team to kind of at least help us as a team work through. Ultimately fell back on, kind of like Dr. Linda said, about, what is medically legally, what are the things we're supposed to do and have to do. Doesn't always make it the best, but that was an interesting situation I've never been in before. So.
Thank you. I think you mentioned an ethics team, and our hospital system, does have an ethics consultant, and on occasion I've, run questions like that by the ethics team. What do you think about this? Is somebody threatening to sue based on this? And you can talk a little bit about that, after some further context. But I think that's that's a useful use of a second expert perspective that would be able to help guide one through this. Dr. Bashevitz, are there some Q&A or chat comments that you want to bring up?
Well, there's some general comments about destigmatizing, but I wanted to add that I think sometimes the no-show notes, no-show to the patient notes are a little bit problematic, or at least I view them as problematic, because what I try to do is have the idea that eventually the patient can see the note probably by requesting from medical records or by a subpoena to the court. If they follow through with something like that, even though I have put no show on that note. So, that's why I think it's problematic. I try and write notes that I would be okay with showing to the patient.
I agree. I can't even recall using this. I know it's, as Linda commented, when you perceive that the note will cause harm viewed by the patient, but really it should be accessible to the patient. And I consider kind of a paternalistic view in medicine that I haven't really had a context that my writing a note where I felt it should be no show. Like I'm hiding something that I think will upset the patient, and then I need to reflect on, okay, well, why is that, and how might I not have that occur? All right, so moving forward, the provider meets with the patient and, after listening to concerns, explains the basis for the diagnosis, that it's a medical diagnosis, it's not pejorative. The patient views the diagnosis as labeling, and that it will impact her ability to get pain treatment anywhere I go in the healthcare system, that it could be treated poorly, like an addict. She provides several instances and specific examples of poor quality care, drug seeking when she had pain from a prior infection, misinterpretation of toxicology screens, and abrupt medication changes, other examples. And some of this is absolutely true, but some of this was in response to very severe complications from substance use disorder, the overdose, for example. The provider also discusses the case with hospital ethics, and they advise that there's no basis for changing the documentation, charting, or legal claim based on the documentation, and also that an action hadn't been taken that caused harm or adverse outcomes, so there wouldn't be a basis. So it wasn't like something had been done and she suffered an adverse outcome from that. And again, importance of documentation appropriately, using medical terms, destigmatizing. So panelists, any thoughts or comments on working with this patient through her hospital stay in terms of staff interactions, which have been challenging? Don't want to get bogged down in details with medication use and administration, but just in general, maybe some where we fall short. Dr. Wong, you had already commented a little bit about this. The nursing wanted a PICC line with a lock that would show tampering, a costly but increasingly common intervention for almost any patient that had diagnosis of substance use disorder and required a PICC line. And eventually, how do you get her to appropriate support and follow-up? I know that there's a lot here, but we have a second case, so I don't want to go into too much detail, but just some generalizations. Catherine, we'll start with you.
Sorry, I'm having struggles with my mouse. I think overall, I would think about like just trauma-informed care and ensuring that we're providing choices, empowerment, safety, and collaboration. So for me, it does seem like with this particular patient, co-creating notes would be the way to go, and figuring out even how we are kind of explaining things. I would also utilize like psychoeducation, right? Like, and sharing information, that idea around like motivational interviewing and how you go about sharing information that you think it's important and pertinent for the person to know. I would take opportunities to teach this concept called teach and learn, instead of like assessment, or instead of kind of coming in to diagnose, but taking opportunities to teach and learn both, right? Like I'm also learning from this person, right? What their story is, what works, what doesn't work, so on and so forth, but also taking opportunities for me to maybe impart some knowledge, teach something, share my concerns, right? So thinking about it from that psychoeducational lens and not diagnosing, but providing information that can also empower this person, right? Or the person already has a lot of awareness and knowledge. So that's a strength, right? And also affirming that. And yeah, those are some of my thoughts.
Great. Dr. Wang, do you have any
I have
final
many thoughts about
comments?
this, but just to re-emphasize open and honest communication, listening to the patient whenever possible, trying to check yourself as a provider and always ask, like, is this approach paternalistic? Am I doing something top down and not really listening to the patient's concerns or priorities? And I just want to make a quick, point about the whole PICC line with a lock that would show tampering. I think any kind of an intervention like that is a setup for magnifying our implicit biases towards people who use drugs and reinforcing stigma. So if any intervention like that is even on the table, it really should be offered and provided and done for all patients who get a PICC line, not just for patients who we are worried that they might have a substance use disorder or they might be misusing their substances.
Yeah, that's a great comment. And it's interesting because it's a very expensive process to do this. But absolutely, and I've seen, then you take a segment and say that there's difference here, and it is a stigma to have that. So that's interesting. Dr. Bishevitz, any final comments?
The only final comment that I would like to say is your question is how to get her to the appropriate support and follow-up. I think the main thing is to realize that you may not. And, all you can do is recommend and try and work with her carefully and slowly and calmly. And, sometimes you're just the beginning. You're just maybe the first person who tried to help her with this diagnosis of opioid use disorder. And she may listen to the fourth person or the 10th person, who knows, but at least you're starting along those lines.
Right, yeah. I think some frequent contact, stabilization with buprenorphine in the hospital is going to be a long hospital stay. It was very complicated with even getting the microinduction complete, with declining a lot of meds, but showing her that we're listening, that we have some effective techniques, and at some point, hopefully, she would agree to maybe talk to a peer counselor, recovery coach, and feel better. Dr. Sullivan, any final thoughts?
Yeah, I think final thoughts may just be more like in a general term is, continue to destigmatize within your institution, continue to give lectures to learners and anybody who will allow you to talk about, everyone wants to sometimes talk about pharmacology, physiology, but, and if that's what you get asked to do, squeeze somehow stigma and, in patient care into every talk. And just start, right there with the language that the people in the hospital are using with each other with regard to these patients. And, that's not a good thing to make sure you do as well.
There was a comment, I think Dr. Wong said, just what good thing am I going to do today? I'm going to do one good thing for you today. I try and, as healthcare is really stressed and resources, time, shortages of staff, patients really can see and feel the stress and trying to take a step back and say, okay, what am I out of this encounter? What am I going to try and leave with the patient? So I just a couple of quick comments on educational pearls, cocaine and use and effects. She had been using cocaine. That's not the primary issue here, but it really can have impairing effects on wound healing with the adulterant, with levamisole, immunosuppression, neutropenia, vasculitis, leukoencephalopathy, and in particular, at the early phases, she'd been using cocaine right prior to admission, movability, interruption of treatment engagements, and so there's some particular problems there. She was also off of the buprenorphine and using fentanyl. I don't want to get bogged down. This is a protocol for microinduction. If anybody had questions, we did mention that. We've discussed that at prior case conferences as well. So if you're interested in the microinduction and how that's done, please take a look at some of our prior presentations. And we have buprenorphine and medications for the treatment of opioid use disorder, methadone. This patient was being titrated up buprenorphine with full agonists in the hospital on top. There are some medications that may show some promise, and craving topiramate has been studied, and as a GABAergic agonist leads to reduction in dopamine levels and reward associated with cocaine and cue-induced craving, and is a medication that I'll use off-label. And disulfiram is another one in a different mechanism, inhibits dopamine beta hydroxylase, and so you have excess dopamine and reduced norepinephrine. It's thought to reduce dopamine-associated craving and reward. And this is an effect that's independent of the effect on reduction of alcohol intake. And so I, at some point, want to circle back around as we establish rapport and try and talk about the cocaine use as well, and maybe consider adding topiramate and looking at titrating down the pregabalin, as at least with the overdose, it looked like just the twitching myoclonus, that probably was a component along with other opioids, fentanyl. All right, so let's move on to case 2, and this is there has to be a better way to do this. So a little bit about harm reduction models for alcohol use disorder. 64-year-old male, long history of alcohol use disorder and medical complications from his chronic use of alcohol. Numerous detoxification visits interspersed with inpatient treatment, hospital visits, brief links to halfway houses or shelters with rapid return to use in very unstable housing community support, often because he's discharged from the level of care housing due to his use. After the 15th admission of the year, the admission provider reflects on the patient's treatment arc and thinks there has got to be a better way to do this. The patient had been at a housing unit, the special program coordinated between the Department of Social Services and a local grant program. He'd been drinking there and found drinking, and also that someone was staying with him who'd been using crack cocaine apparently, and so he lost his housing. Of note, the apartment was in an area of the city, a lot of crime, street-level drug use. Alcohol is readily accessible at corner stores and a nearby liquor store. While dependent on alcohol, up to a liter of vodka daily, at times natty daddy beer and other forms of alcohol, including mouthwash in the past with other options not available, the patient reports the primary reason he came in was loss of housing, violated contract by drinking, having someone with him who was using substances. So my question is, what are some harm reduction strategies in general related to alcohol use disorder and severe alcohol use disorder and all the comorbidities? And how do you apply them to this patient in this situation, or are there options where you're practicing? And do you have any experience with housing options that allow alcohol consumption or allow it but limit to certain types? In the past, this is colloquially called like wet house, and that may be even certainly stigmatizing, but that's what at least in the past it's been referred to. So I'm gonna jumped ahead. So let's start with Dr. Bishevitz. What is your experience? Do we have any of these options in the area?
I still don't. I don't believe that we have any options for housing first, so-called wet houses in the area. But I could be wrong. There are advocacy groups that advocate for that, and frankly, I agree with them. I think that this is an idea whose time has come, and these folks get into a lot of trouble medically, and it's very difficult to deal with this. And another way to refer to this as housing first, and housing first is the theory that a person needs housing first to feel better, very simply, and to feel like a human being and go forward with whatever they need to go forward with, whether it's harm reduction or abstinence-based treatment or whatever it is.
Right, some great comments. I think look at hierarchy of needs, and having housing is certainly important. Dr. Sullivan, any experience of resources and where you're working? Thoughts about that?
Yeah, unfortunately, I really don't know of any local places. I mean, there are places where people live in in settings with other people, where maybe they do drink, but maybe they're not supposed to. I'm not really sure of a decently structured housing system out locally. I do know that other cities in the country, I think in like San Francisco and some other places, have kind of modeled this program, have showed excellent success with it. And in terms of just harm reduction strategies for alcohol, it's different. A lot of times we talk about opioids, and the thing about that is that there's alternative medications that may be safer, and alcohol, the jury is out. So that, how do you actually do that with alcoholism? But I do the same thing. I try to rapidly get them on a medication if possible, maybe not as efficacious, and also try to teach them maybe some safer ways of maybe of drinking alcohol. But harm reduction, I would say, in alcohol is a little bit lagging behind, maybe in terms of in the theories that exist for opioids.
Certainly exploring what medications, what types of treatments has this individual experience. I've come across patients that have been many contacts with the system, but never have been offered naltrexone or some of the other medications for craving, or really understood what the clinical effects were. I thought that every medication is like disulfiram. A lot of the housing options, even that patients have available, I just am, impressed that anybody is able to even remain sober in some of the options that we have for them. Dr. Wong, do you have any comments, experience with
only that
housing
I'm very jealous that in Canada, they have a strong history of having managed alcohol programs where they really provide housing, other social supports, in addition to regular access to beverage alcohol, right? To sort of help patients be in a safe space, experience support, have access to all of the social services that they need, because those have been helpful in reducing homelessness, poverty, and also helping with the addiction side. So I wish that in this country, we really had those safe spaces for our patients, because it is a struggle for us in our program for patients with alcohol use disorder. I think we end up doing a lot of motivational interviewing based counseling to try to work with patients, try to understand how they're drinking and help them optimize it so it's a little bit safer, right? And to work with their family members and their community. But I do feel like this is an area where we, as a country with, a non-single payer health system and many different barriers related to insurance, we don't deal with this well. But I will say that I definitely have encountered patients who also access non-beverage alcohol, and that's also additionally a problem because of the additives and other things associated with it. So, I think talking to patients to get a sense of exactly objectively what they're doing in what setting, and trying to optimize it so that at least it's a little bit safer, and so that they know that you are a provider or a space that they can come to if they do have any additional issues. And, I work very closely with Catherine and our social work team to sort of help address this, because I feel like our social work team is really like the pillar that really helps in these situations, because there's just not that much. I mean, yes, like if I can try to convince someone to get on naltrexone, but many of our patients don't want that. And so what do you do in the meantime?
Some great comments. Do you know that the models in Canada, do they limit to particular types of alcohol-containing beverages, or in the housing units, or are there models where it's patient preference?
I don't know. That's a good question.
From what I've looked at, but I don't have a comprehensive understanding of this. Some of them, I believe, limit to certain concentrations in order to try and limit the high concentration liquor to avoid potentially some of the more acute concentrations, as well as the rapid rising in concentrations. But I don't have experience in the United States with models like that. Certainly, if I were in charge, I'd take the houses and apartments and put them outside of the areas where there's reminders of the substance and availability at every turn of the head. And much more support. Catherine, can you comment on your experience?
I don't know of any wet houses either, but I do know that they do exist. And it sounds like, at least in some states, it's like a combination between like the Department of Homeless Services, or DHS, like Department of Social Services, and at least one program that I read about, St. Anthony's in Minnesota. It's also a partnership with like Catholic Charities. So where people are then allowed to drink in the safety of their homes, right? Because that's one of the harm reduction strategies for alcohol use, is to try and use in a safe environment, safe place. And sometimes that's in the comfort of your home. So if in the absence of shelters, right, that will allow someone to drink, then it would be trying to connect them to the housing resources that would potentially offer them or support them in getting access to some type of voucher where they can maybe live more independently. But that depends on the person, right? Like sometimes you have people that will benefit from living in some form of supportive housing where they're going to have services on site. But then that limits, right, their capacity to be able to live independently and freely and autonomously. But if they can function and don't necessarily require supportive housing, what would it be like to connect them to a program that will get them a voucher where they can then live out in the community independently and be able to possibly set up some of these harm reduction strategies that can be supportive for them. I would want to, in particular with this patient, know and understand what their goal is in relationship to their alcohol use. What do they want to accomplish? And through that, then engage in some type of cost-benefit analysis of their drinking, and begin to discuss like what is possible, right? Ensuring that, again, trying to do some psychoed or just sharing information around drinking water, alternating between drinking water and drinking, making sure you eat before you drink. Yeah, those are some of my thoughts. And also just thinking about like dosage and frequency, like, is it possible to have beers, right, instead of like strong alcohol or liquor? Are there moments, hours, right, that can we plan for moments and hours, if not days, where you can be alcohol free? If, again, all depending on what the goal is for the person, right? Because that would be what would center then the harm reduction strategies that you can offer.
Yeah, those great comments. I think in particular, as people really experience the severe complications of chronic persistent heavy alcohol use, including neurologic, the Wernicke-Korsakoff syndrome, severe damage to other parts of the nervous system, yet still crave alcohol, and it becomes a supportive yet almost a palliative care model of care when you get to that level, and discharging someone from housing, and it's really thanks to question that the system that we have for this, when we look at it as a disease, really, when somebody has end stage alcohol use disorder, we really don't do a good job in the disease model of treating. I just wanted to, there's been some publication on health first and youth in the United States, and this is one article from 2009, and they're familiar with quite a few different systems-based approaches that have looked at very high healthcare utilizers, often substance use disorder, mental health, and homelessness all kind of tied in together. And when you house individuals, you look at and offer other supports, typically before and then compare after. You have huge cost savings. I mean, looking at 15 detoxification unit visits, the hospital visits, the shuffle between different programs. I mean, there were some supports for this patient, individual care manager, health home, but the system wasn't really communicating. So a lot of potential savings when people have looked at, housing first models. And in the studies I've looked at, the length of time in housing was significantly related to reductions in use and cost of services, with those housed for the longest period of time experienced the greatest reductions. So again, housing is important, critical. We're getting close to the end of time. We've really covered kind of what types of resources have been effective in reducing healthcare costs. In general, we talked about this, housing first and collaborative through the system. So I want to jump to my final thoughts so we can stay on time. And I have actually two, and these are from The Sun this month. The Sun is a literary magazine, and the first is from Herman Hesse from Siddhartha, and I think it's very appropriate for the patients we're discussing today. And this is, I have had to experience so much stupidity, so many vices, so much error, so much nausea, disillusionment, and sorrow, just in order to become a child again and begin anew. I did experience despair. I had to sink to the greatest mental depths, to thoughts of suicide, in order to experience grace. And that's from Herman Hesse. And the second is Rachel Naomi Remen, who says, wounding and healing are not opposites. They're part of the same thing. It is our words that enable us to be compassionate with the wounds of others. It is our wounds that enable us to be compassionate with the wounds of others. It is our limitations that make us kind to the limitations of other people. I think I've served people perfectly with parts of myself I used to be ashamed of. Well, thank you. Next Addiction Toxicology Case Conference is December 3rd. We anticipate covering update on synthetic and designer drugs and having, again, some expert panelists join us. And so mark your calendars. Remember the abstract deadline, the 15th for ACMT. And please check both the American College of Medical Toxicology and American Society of Addiction Medicine websites for past recorded sessions and the FAQ page. And I want to thank our panelists for participating. Thank you for some great discussion. And again, thank the audience for attending. Have a great weekend. It's daylight savings time and we gain an hour. So I'm very happy this weekend. Thank you.